Hey everybody, welcome back to the Pre-Hospital Paradigm Podcast. I'm Scott Wildenheim. We got Caleb Ferroni as usual. Continuing on our interventional cardiology and our STEMI of this and our STEMI program of this entire month, we've got Dr. Greg Stefano. He's back with us, and Jeff Patty, he's an RN, is our chest pain coordinator for Geauga Hospital, which is one of our community hospitals in the UH system in, shockingly, Geauga County. Guys, thanks for coming back. We're here at we're doing our road show, right? We're here at Bainbridge Township Fire Department, and again, we're getting out in the world, and every single month on the fourth Monday when we're out, instead of doing that live show in the studio, we're trying to be out in the community where it's where medicine happens, right? Where EMS medicine happens. So, if you're interested in having us come to your department, prehospitalparadigm.com. If you click on a podcast, down at the bottom there's a web form. If you fill that out, you'll get put on the list. So this first couple of months, we're choosing kind of where we're going, as this is new for us too. We just started this here in 2024, and as it evolves a little bit, once we get settled in, we'd actually like to draw live on the air where we're going next, right? So we'd really like if any of you have the capacity and want to host us and have us out for your department. Again, it'll be on the fourth Monday at 7 o'clock.
Or hospital.
Wherever. If you fill out that form, we'll likely pull that out live on the air, and then we'll come see you a month later, right? So hopefully that's we can get some people to log in. Again, prehospitalparadigm.com. If you click on the podcast down at the bottom, there's a link for the roadshow, and that's where you find that web link. So, in addition to that, all of this is being powered tonight as we kind of broached the subject last month with our last live. All of this is being powered by FirstNet, so they've graciously sponsored the podcast. Everything that's going out, streaming on Facebook and YouTube right now. Of course, FirstNet is the first responders wireless network, right? In addition to that, we've got a deal if you are not a FirstNet subscriber. Again, prehospitalparadigm.com/FirstNet, and a deal that they have for our audience that are first responders is there for you to review and look over and hopefully take advantage of. So we would absolutely love that.
And if Palmadine made internet, we would probably go with Palmadine. So.
And he continues to be paid off by the Palmadine rep. In addition to that, so that's the backbone that's getting it out, all of our streaming out into the world, but all of that's being supported by Cradle Point, who's also graciously supported the podcast, and they produce the actual hardware, the wireless routers that go out put all this data out over the FirstNet network. So if you're interested in either one of those, again, prehospitalparadigm.com, check that out. We have Lieutenant Bolt from Bainbridge Township Fire Department. We'll give him a few minutes. Lieutenant, if you want to say a little bit about your department, and of course, as expected, the EMS gods have not been kind to us. So literally just before we went live, tones dropped, everybody took off, leaving you the lone man from your department. But hey, we appreciate you having us out here, and the floor is yours, man. Tell us a little bit about Bainbridge.
Well, I'm happy to welcome the podcast here to Bainbridge Township. We are 25 square miles located in Geauga County. We staff 4 to 5 members a day. We run about 2,200 calls a year, 1,600 of them being EMS calls. Our shortest transport, best case scenario, is usually about 15 minutes to a Geauga hospital, and our longest transport, depending on weather, can be 35 plus minutes. That's about all I got. I just want to thank you guys for coming out. We're looking forward to hosting today.
No, like I said, we appreciate you having us, and thanks for telling us a little bit about your department.
Thank you.
So, all right, now on to the meat and potatoes. All right, so over the past 3 weeks, of course, the pre-recorded stuff is aired, and like I was kind of telling you guys off air, we had some very positive feedback, and you know, people have been very interested in the message that you guys brought to us. So, having said that, just kind of a little bit of recap before we start diving into some of these questions and any questions that they may have out there. You kind of just run through an activation for us from a field STEMI situation. So we as EMS, we get the call. Of course, they took off, they go out there, they get an EKG, they got a Wonkus 12 lead. What goes on behind the scenes from the time we transmit that till the time you guys are floating a wire and going to work on that STEMI?
Yeah, great question, obviously. You know, I think most importantly, with what you said, is to always transmit up front. You know, never have, don't be in fear that you know, you're activating the STEMI. And I think that the majority of success that we've had throughout the system, you know, really is all because of early activation from EMS and getting everybody ready to go. So, I mean, I think that always send and always, you know, have confidence in what you're treating. And I think that, you know, we've seen that confidence build, especially over the last 5 years, with treating how aggressively we do with medications in the field. From our standpoint, once that, you know, page goes off, you know, it goes to a central station within whichever local hospital ED. And that's set off by the LifeNet paging system, and then you know, the ER physician or staff then you know, sends out, you know, gets in touch with us. That page goes it goes centrally through the ER, but then the on-call teams receive those pages as well. You know, which includes, you know, an interventional cardiologist, the nursing team, and the techs, plus minus fellows involved if they're you know, at an institution where fellows are training. Sure. And then, you know, depending on time of day, you know, because that's actually the main split, is if we're there, you know, we're all hands on deck and we're going to be in the ER waiting for you. You know, and if we're at home in the middle of the night, then we're coming in as fast as we can, always in under 30 minutes. You know, the staff is expected to be there, and we're ready to roll. I don't know what else you have to add to that, Jeff.
I just think that basically what you said, the LifeNet system is really one of the keys, and early activation is the key. The LifeNet pages everybody simultaneously, so the nursing supervisor is working on getting us a bed, our team is getting notified and woken up in the middle of the night, or during the day where sometimes we have to empty a cath lab to get ready for the heart attack patient. Whatever the case may be, there's a lot of activity going on once the pager is activated. But you guys activating in the field is a huge key to our success. It gives us a head start. A lot of times, you know, depending how rural you guys are, we might beat the squad in the middle of the night. You know, if it's coming from the, you know, way out in Ashtabula County, we could very easily be waiting for you when you get here at 3 in the morning. So it really is the key, like Dr. Stefano said.
The one thing I think is worth mentioning is that STEMI activations work out really well, especially at Geauga Hospital. If you have a medic squad calling a STEMI activation or saying, this is what I think I have, it's really taken to heart there, and you guys are put together and you're responding to it. We're not so great in other areas. I think stroke care is one of them where I continuously hear medics saying, we've called a stroke alert, we get there and it's like, oh, we should probably do a stroke alert. And it's like, we activated that. But I think on your end of things, it's amazing how well it's interpreted and then taken, and the baton is passed off. And it's just, you've got it down. So if you can help maybe some of the other sides of that, it'd be great.
Yeah, no, I think that's, you know, what's great about having these, you know, multidisciplinary teams, and even just talks like this, is that, you know, you hear feedback like that, and, you know, stroke is a little bit different of an animal in terms of definitive treatment at times, but in terms of time to diagnosis, it's certainly not.
Yeah.
You guys know, having to have the scanners open and things like that. And I think that certainly, how responsive our EMS is and how well trained, certainly I think these are things we can, continue to build upon, going to the other places for sure.
So a couple things that came that just to build off a couple things that you guys said. So one of them was like during the day, you may have other non-acute cases in the lab, right? Yep. And you'll shuffle the deck and kind of set them aside. Obviously, not if you're in the middle of a procedure, you have to finish it or whatnot, but you'll shuffle the deck. You'll reprioritize if we activate from the field.
Oh, absolutely. I think once that field activation occurs, we're certainly dropping everything.
Sure.
To reason.
No, understood. Yeah, right.
If we're not already doing a intervention, but that becomes top priority, and it's door to balloon time is what we take most seriously. That's Jeff and I, for certain.
Absolutely.
In terms of quality metrics, because we know that intervening and getting that vessel open is still the number one way to reduce morbidity and mortality.
We try to train our staff that when that STEMI walks in the door, it's now the sickest patient in the hospital. Stop what you're doing, grab something, let's all hands on deck, let's get this patient ready for the cath lab as quick as possible. If there's somebody that sometimes we need to delay a same-day patient, we'll do that because we know that patient is having an MI and we need to get him in the lab as quick as possible. We need to get that vessel open.
So this is kind of maybe an off-the-wall question, but if you have a patient who comes in and maybe co-issues going on, you have a patient that's possibility of having a STEMI, or you see the STEMI on EKG, but the patient's also there, stroke alert, and that maybe a CT is warranted, which comes first?
That's a great question. So the CAT scan would always come first. You want to make sure that you're not setting yourself up in a hemorrhagic stroke situation.
Yeah.
And we're pounding anticoagulation on top of that. But certainly, there are scenarios of gray. But again, that's why it's always just hit the button. Just hit the button. That gets us all involved. It gets interventional cardiologists involved. ER physicians can look and see what's going on. It gets EMS involved. I mean, we're all working together at that point to take care of the patient, who's not even in the hospital quite yet. And it's amazing. But in these gray cases, certainly it's not a green light go. I think that specifically at Geauga, you guys, if you brought somebody in, if it's at 2 p.m., most likely you'll be greeted by Jeff and I at the door. But in that upfront scenario, we've done this enough. If straightforward cases, we take straight to the lab. Literally, we'll come from ambulance bay right to the lab. No reason to stop in the ER. If there is some equipoise in diagnosis and we don't quite know what's going on, and there's some subtle stuff, it's okay then. Just take a step back. I think that as much as we push, STEMI, go to the lab. The majority of time where I'm now having to reel people in is, okay, it's not, there's maybe something going on, and I see what you're talking about in the EKG, but also, taking, this patient with potential multiple other comorbidities to the lab, isn't
the risk benefit
isn't exactly.
Yeah,
so let's maybe take the 5 to 10 minutes to sort it out with basic lab work and some imaging if needed to sort of get a broader
to that point, I think that I've not recently, it's been a little while ago, I was at a department where somebody said, I'm a little hesitant to call STEMIs because I did call one, and on the way to the hospital, the doctor must have interpreted it, which I'm assuming was you. We get there, and then the ER doc says, you know what, they didn't activate because they didn't see what you saw. And they're like, well, then maybe I'm not seeing. It's like, no. Err on the side of caution. Absolutely always err on the side of caution, and don't take that to heart.
It's the one you don't send.
Exactly.
Well, and two, that's exactly right. I have one of the very first STEMIs that I did. It was a classic. 4 millimeter ST elevations. This was before we were really well tuned and transmitting
Sure.
in a well-oiled machine. And clearly, the squad, there were 4 or 5 millimeter inferior ST elevations, and when they got to the ER, normal EKG, pain free.
Yeah.
Well, did they medicate the patient on the way?
Well, and they did, but we still took that patient to the lab, and there was a big 99% thrombus in the middle of the artery, and so all information is valuable, obviously, and like those dynamic changes that happen. Happen all the time. When the vessel closes and opens, you're going to see.
But to that story, I mean, if the medics are medicating the patient on the way, they probably gave them that relief in the STEMI that you were seeing, then it was probably the medicine working, and I think that's an amazing story. That it's like, if that hadn't been given, where would they have been when they finally got to you?
Yeah, no, I mean that's exactly right, and I think that's something that as interventional cardiologists, we are always thinking about the mechanical and the metal drug going in there, but like you said, treating with antiplatelet agents and further anticoagulation loosens that plaque up,
Right.
and a lot of times they're pain free when they roll in, and even
Right.
in the lab, right? And that's always the funny, not funny case, but it's where the staff is like, oh, what are we doing? Why it's 1 a.m. and then the patient is calmed down. A half hour ago they're 10 out of 10 chest pain and diaphoretic and screaming, and then we're there in the middle of the night and everything's calmed down. They're like, what you doing? And then you take the picture and you see a vessel hanging on by a thread that could close up at any minute. So I mean, I think that that's a scenario we see quite often, actually.
Sure. And I think we need to take a step back for the audience that may be watching, not necessarily here, because all these folks are under our med control, clearly know what we expect of them from a pre-hospital care standpoint. But we are doing P2Y inhibitors in the field, and we're heparinizing in the field. So when you're asking about medicating, and when you're speaking about medicating, you're speaking about in the pre-hospital space. We're not talking about in the hospital, and that's why a few of these cases that you referred to, not only just now, but in the pre-recorded sessions, right, where these patients are being delivered in certainly more optimal conditions, and of course setting them up for hopefully more success once you get them on the table, right?
Certainly.
Yeah, all of our squads, critical care transport, air transport, all the EDs, we all have the medication available to be given, per protocol, and it's all the same protocol throughout the UH system.
correct.
Doesn't matter if you go to St. John's. If you're St. John's under their med command, you're going to give the same meds as if you were at Bainbridge. So it makes it easier, and he knows what to expect when the patient comes in with a STEMI. Have you gotten the meds? Yep. You gave full protocol meds? Yep. So we usually check that off. And I can't even remember the last time we had any issues with protocol medications. I mean, it's sort of automatic now.
There is a question here. It's really speculatory on your behalf, but I'm sure you guys have had some conversations with colleagues before. Basically, what is the reticence from other doctors about us giving specifically? The question is specifically about heparin. I'll expand it a little bit to heparinizing or giving a P2Y inhibitor like Brilinta, ticagrelor in the field. What do you think some of the reticence? I mean, I know we do it, right? But
Well, I think that the main reticence would be if something else is going on. If they're bleeding or something.
Sure.
That, I mean, as silly as that sounds, but a lot of times, if you have a hemoglobin of 7 instead of 14, then
Right.
you're functionally already inducing 50% blockages everywhere, and you can definitely see ECG changes quite
course.
often. And I just had 2 weeks ago the exact same case. It was a lady who came in as a STEMI. Story was was a little goofy. EKG had some subtle ST elevations, but the story wasn't that great. Subsequently her hemoglobin was 7. So I think that's a scenario where this individual had walked in through the ER, so there wasn't any, EMS involvement in needing the decision to give anticoagulation. But again, I mean, this was a little bit off, case, but I think that would be the main issue. A lot of times there's, it's all bleeding. I mean, it's just, if people are on, I know that there was a case, one of my colleagues was discussing with me a few years ago, not like, giving Brilinta, if a patient's on a DOAC, which are the new anticoagulants, Ixaban and Xarelto and these drugs that are mainly used for atrial fibrillation that have replaced warfarin over the past few years. But I mean, I think practically, if you're in a situation that's a otherwise very viable and normal, healthy patient from home, you really should not have too much reticence about giving heparin in the field, or aspirin or Brilinta.
Great. Did we have some questions out in the?
Yeah, I got a question.
the
Just
audience?
because we were.
Oh, he's got. Okay, good. He's got the mic. I didn't see the mic there. I was like,
So we were kind of going over like the pre-hospital, everything that's going to go on when we transmit an EKG, and we have some longer transports and everything. So I'm sure a lot of the departments, we transport. If we take a 12 lead and we're transporting to a facility, we're going to transmit it. Whether it's
fantastic.
for whatever reason, even if we find out something else, if we took it, we're going to transmit it. If you could just kind of go over the process of what the hospital is going to do as soon as they get that. I guess who's going to get that? Where's it going to go? How's it going to make it? Is it just going to go to the ER doc and he's going to forward it to the cardiologist? Or I guess if you could just go over where it's going to go and everything.
So I know at Geauga, when the LifeNet receives an incoming 12 lead, it dings and they have to physically go over and turn it off, and it auto prints right behind the ED doc. So usually when he hears that binging, he knows to turn around. Or when somebody sees there's a dedicated paper tray that only spits out 12 leads. And when somebody hits to shut the alarm off, they typically go over and hand the physician the 12 lead. So any 12 lead that comes in by LifeNet gets seen by the ED doc. And very, very rare, I can't even remember in the last 6 or 7 years, once or twice it got missed, and it was usually because the doc was taking care of another critical patient in another room. But that's typically the process. And the ED nurses and medics are pretty well trained that if they look at it and they go, ooh, acute MI, they're going to show to hey doc, did you see this possible STEMI coming in? So they're pretty good about sort of reinforcing what they're already seeing, and so that before the squad even calls report, they typically know that, hey, we might have a hot STEMI coming in. So, but that's typically the process. Almost every EKG gets seen by the doc within 4 or 5 minutes.
And did they then push the button to light you guys up?
So then the process of activating the STEMI. So if the ED doc sees the EKG and determines that it's a STEMI, he'll either do it himself, or most of the time one of the nurses will say, hey doc, do you want me to activate this?
Right.
And they'll activate immediately.
Yep.
In some instances, the docs may wait till they hear report, but it seems to me that most of the docs, Zimmerman, Derdala, they're all very proactive about getting the page going sooner rather than later. And if you ask Dr. Stefano, he'd rather know early. You can always cancel us. We can always go home. We'd rather be there early and be able to take care of the patient.
So, like sometimes we might be doing a 12 lead in the house or something at the patient. So we might get the 12 lead right then and there, and we might see ST elevation, but then we still got to move them to the cot now because they're on their couch. We get them out to the squad. We got 5 minutes of vitals in the squad. And then as soon as we start driving, that's when we would normally make that phone call to the hospital, let them know that it's... So in a perfect scenario, you might have already seen it and seen the ST.
Yeah.
But you might not have. So, like, would it be... It sounds like what we're talking about today might be more beneficial for us to kind of make that STEMI call right then and there in the house.
Yeah, I mean,
'Cause
that's sort of
people-
what I was gonna say. I mean, I think that it, rather than, be subject to, the limitations of transmission, I mean, yeah, if you see it and you're like, okay, we can't technically transmit it, but hey, quick call, heads up to the ER, listen, we're not gonna be able to transmit this for 10 to
Time,
15
right, yeah,
minutes,
yeah.
but we got a STEMI, I think. I think that's really reasonable.
For sure.
I mean, I think that then, because it's just all that time on the back end of getting everybody prepared. I think that universally, at least speaking for myself, I mean, that is the mechanism that it should happen. I have no problem being alerted of a possible STEMI where I don't have an EKG. I mean, that's okay. I mean, we're taking care of a patient, and you guys are, right out in front of them at home, and we got to be ready. I mean, that's the bottom line. And, and there's no, negative points if it's not a STEMI. I mean, that's the bottom line.
Yeah.
I mean, I
Yeah.
think that anything, any negative feedback around, that kind of activation is really not part of what we do at UH for certain. So, I think in that scenario, yeah, I mean, if you're at home and you got 10 minutes and just say, hey guys, give just a quick heads up to the ER and tell them we're, coming their way and we'll send the EKG in 10 minutes. And I can tell you, even at 1:30 a.m., I mean, as much as I would be, grumbling a little bit, I think then I would have to then remember, what we do and why we do
Yeah,
this.
there's
And
even on the
then
other end, yeah.
everybody's on the, we're on the way in. And I think that we'd much rather call off, turn around halfway home. In that scenario, rather than be 20 minutes behind and the patient have VF arrest because, they weren't revascularized 10 minutes sooner. I mean, because then that's the bottom line.
And our squads have to remember too that the interpretation of a 12-lead may be a paramedic skill, but the application of one is a basic skill. So anybody with chest pain or abdominal pain should be getting 12 leads from basic providers to medics and hitting transmit. And if a basic picks something up and sends it to you, they might not know that it's a STEMI, but when you see that, when the doctor sees it, they'll activate it before the basic squad gets there. And we see that quite a bit at Geauga because we do have quite a bit of still volunteer departments that are responding. But just, it's so important that at the basic level, the paramedics are teaching and the doctors are teaching to put on 12 leads and do it appropriately.
Just get them. Yep.
Yeah.
And at least get them.
Well, and then too, sort of on the flip side of that, I mean, if you, you're looking and you're in the field and, yeah, I mean, there's some subtle ST elevations and, man, I don't know. I mean, that's okay too. I mean, this isn't like oh my God, I missed a subtle STEMI and we didn't give the medications. I mean, I think that there's a, really fine balance
Fine, yeah.
that you shouldn't be felt pressured that, oh my God, am I missing something?
Right.
And I think that just having that open line of communication, is the best way to do it.
And for the paramedics, I know I've had colleagues in the past that have been concerned about what to call it, right? They're blanking on what pattern or what do I call this, right? And in that phone call, just explain what you're seeing, right? I have ST segment elevation here, here, and here. I've got depression here. Just describe it away. You don't have to necessarily write this dissertation on what it is you're seeing. Just explain away what it is.
And then I would say, remember, go back to EMT school. What does the patient look like?
Present? Yep.
Yeah.
Does he look?
Tell
is
me
he
the story, right?
Clutching his chest? Is he diaphoretic? Is he pale? I mean, with the EKG is a whole different story.
I think the first week of medic school, when I start teaching a group, it's always remember that paramedics lean on the basic EMTs, and I've said it on the podcast 100 times, but they're the ones that are going to sit there and tell the paramedic who's buried in the monitor, hey, the patient's not breathing. You need to do something. So
His EKG looks fine, but he looks terrible.
Yeah.
we call
Well, I mean,
this PEA.
Well, I mean, that's another point that we stressed in the recorded, but let's say it again here just to make sure we're clear on that, is the absence of STEMI on an EKG doesn't mean that the patient's not having some sort of acute coronary
Right. Absolutely.
event, right?
You need some more diagnostic things there.
Correct.
Whether that be chemically or imaging, you can't. It's one piece of the puzzle now.
Right.
Now, question for me, the flip side of that, is there ever a situation where a STEMI on an EKG is not a patient that has a completely occluded coronary artery.
Yeah, I mean, that happens a lot. The two main scenarios which you're going to have that is, one would be pericarditis, is I think the most common, especially in our post-COVID era, or I guess I probably should have just left that alone.
Just let that, yeah.
But then nonetheless,
We'll edit that part out of the live show.
But I mean, pericarditis and myocarditis have been around long before COVID, so
There it is.
we're
Well played.
well versed into these changes. And so when you have a pericarditis scenario, it's usually diffuse ST elevations and not localized to our inferior leads or anterior or lateral leads. You'll usually see gross, like I said, ST elevations throughout with PR depression, and AVL is sort of the telltale sign of that. Another scenario, and actually we had one of these within the month as well, is sometimes you can have residual ST segment elevations, and actually we are called about this a lot. It'll be somebody who just had a STEMI.
Yeah.
And maybe if it's a late presentation, so I think you have to think about the mechanism of MI. If you're having a occluded vessel and that muscle distal to that vessel is not revascularized, it ends up dying and then becomes aneurysmal, the heart. So you'll have residual ST elevations a lot of times. So when people have silent MIs, they'll come in and I think they'll have an MI that's not revascularized, developed an aneurysm, and then for whatever reason, a year later or 2 years later
Down the
or
road,
2 weeks
yeah.
later, you come in and you can see that ST elevations, and you see that in the anterior leads. I think those are probably the two most common
Situations,
which you
yeah.
would see ST elevations in the setting of clean arteries.
And with a clean vessel. Cool. Mike, our Mike guy is sleeping.
Hi, so 2 to 3% of patients get sent out for open heart surgery. I guess my question would be, is that because technology has gotten better, that they're doing less open heart surgeries now because you guys are able to revascularize a lot of that cardiac muscle? And also, the question about the levels of the different cath labs, just kind of in this general area. Geauga Hospital, I think, is a level 3, is that right?
Geauga is a level 2 lab. I think that in terms of the cath lab designations, in terms of levels, it's in respect to having a CT surgery program. So the level 1 labs throughout the system include CMC, Ahuja, Lake, Elyria,
Parma.
and Parma. So we have 5 level 1 labs. And then we have various other level 2 labs like Geauga, Portage, Samaritan now, which recently became a level 2 lab in December. St. John's. And the level 2 has, we have interventional cath labs and are able to do percutaneous coronary intervention, take care of STEMIs. Level 3 labs are, just the diagnostic alone. Actually, I don't think we have any more level 3 labs alone. Now that Samaritan has become a level 2 and Richmond has is no longer performing coronary angiography. So I think that distinction really has to do with if you have CT surgery available on site. Now, I can tell you that
Cardiothoracic.
that I don't think that should be a. In terms of STEMI, it really doesn't matter, to be honest with you, because a lot, like if you say, oh, we have a patient who has triple vessel disease, they no longer have triple vessel disease after you intervene on the culprit vessel.
Right,
Now they have
right.
double vessel disease, and Now, there are a lot of scenarios where we'll do like hybrid scenarios. Like if we're at a level 2 lab, you open up the artery, and like, so let's say there's a patient comes with inferior MI, you know, we come in, we stent the right, that's a culprit lesion, get them out of trouble, but they still have significant disease in the left system. If it's felt that it's, you know, best served by revascularization with bypass surgery, we would then, you know, get them to where they need to be. You know, transfer them from a level 2 to a level 1 lab after they've been stabilized. I think that in terms of what, you know, for EMS,
For our purposes,
it's really a wash. I mean, I think that level 1 and level 2, there's no difference in that. That designation has just been simply from the state of Ohio, how, you know, the capacity to do PCI has sort of evolved.
Overall, you're doing less cardiac surgery. Like you're seeing less cardiac surgeries, and you're being able to solve a lot of these problems with just PCI.
I think in the setting of an acute MI, STEMI, yes, but you know, actually I was just on the way on a call about our ACPR program, which is, you know, it's phenomenal. It's been instituted over the last year downtown. So this would be the, you know, one scenario in which a level 2 lab could not be a level 1 lab, and we're getting really, I think, off track, maybe a little bit, but in terms of, you know, the ECPR program, you know, these are patients who have witnessed arrest out of the hospital or in the ED, and actually, if they qualify, they're getting cannulated for ECMO prior to going to the lab. So these are the sickest of the sick patients in these scenarios. You know, patients who, like I said, who having recurrent VF or VT in scenarios like that. But these are, you know, UH has the second program in Ohio, was the second one to do this. I think the initial one was out of Columbus, but we're, I believe, the only one operating still out of Ohio. There's only like 12 centers in the whole United States who are doing this. So I think that, and the way I look at it, it's how we're continuing to push the envelope and get further and further. You know, but in terms of, again, the straightforward STEMI is really no longer a, you know, CT surgery case immediately. At least you know, through the majority of our cath labs, there's always, you know, there's always that case, right? That, yeah, if you've established TIMI 3 flow and there's terrible blockage everywhere, and you've got them settled down, then yeah, then there could be some equipoise about, okay, should we send them for surgery now that we've got them stabilized, or should we do some stenting and things like that?
And realistically, sorry, Caleb, realistically, in a scenario where a patient would need to go downtown or to Ahuja, we're set up. We have a balloon pump, we have Impella, which is a left ventricular assist device, which can help stabilize a patient, and it's a 12-minute flight. So we've got a crew in Middlefield, which could be at our hospital in 5 minutes, and it's a 12-minute flight downtown. So you potentially could have the patient's artery open, them put on an Impella or a balloon pump, and have medevac at the side, AirMed, at the side of the bed, you know, within like 10, 15 minutes, and then they could be downtown in 12 minutes. So we've done that plenty of times. We're capable of doing that. So we really don't have any limitations in terms of what we're able to do other than the open heart. But we can get them to open heart as quick as possible. So if you're, you know, I live in Geauga County, would I take my family to Dr. Stefano? 100%, knowing what I know. And I've been at almost all the facilities. All the UH facilities are phenomenal. We do great work at Geauga, and we're very fast and we're very efficient. And in the event that you do need open heart, we can get you down there real quick.
I think that a key point is, you know, similarly how EMS works as a system, like our interventional center, it works
as a
very,
system, right.
very similar system in which, you know, the lab at, I guess, so we're in Bainbridge, so we have, right, 3 places sort of 20 minutes away, right, Geauga, Portage, and Ahuja, and, you know, places where I've done all cases, and the lab is the same exact setup in every place. You know, I mean, it's and we've taken this approach as a interventional center to really, you know, have a lot of uniformity across
Standardized
the board.
approach, yeah.
You know, so all the bells and whistles are in every lab. There's no cath lab that is more
advanced than
grandiosely stocked than any other. You know, so I think that you know, we've done a really good job creating uniformity, not only in our equipment and processes, but actually, you know, how we take care of patients. You know, we have meetings all the time discussing these cases and what we can do better and continue to push the envelope forward.
Anything else from this group?
Sorry if someone asked this one.
No.
So for EMS crews like us that have long transport times, where we've done everything, we're en route, we're still driving, we've done protocol, we've given all the meds, we've transmitted to you guys, you guys activated the team, IV, everything's done. Is there anything extra while we're sitting in the squad with that patient that we can do that's maybe not on the protocol that helps you guys, benefit you guys, or benefits the ER, or just benefits the patient, like any pertinent like questions that might be special for you guys, or just like medications they take that we can also give, like let you know when we get on like to the ER and give that report, or like anything just like procedure-wise that we can do extra, like 2 IVs instead of 1, or like certain, like you said, the no IV, try to prevent doing it in that right hand. Like that's something that was new for me to hear. So is there any other things that we can do like that that would help?
So I would say first thing is put your fast patches on your patient. You know, you forget that that's the patient statistically most going to arrest, 3rd-degree heart block, symptomatic bradycardia, all these bad things. Put your fast patches on once you find out that this is a STEMI patient. And I would say, if whenever possible, you know, Dr. Stefano is accessing majority of his patients through the radial artery. Try to avoid the hand at the very least, but we always try to tell you, stick to the left. Try to do the left hand or the left AC. That makes it easy. When he's working on this patient from the right side, we can access the IV from the left. And then if you really have a lot of time, if you can get the patient undressed, it's a little challenging in the back of a squad, but it just saves, you know, it does save time. If you can get them undressed under the sheet and keep covered, that saves us 2 or 3 minutes in the lab. But those are really the main things that I can think of.
Piggybacking on what Jeff said, that IV piece in today's day and age, which in the majority of my colleagues are, you know, we do radial primary PCI. You know, if you're sitting there, we're, you know, not sitting there, but obviously you got 5 minutes till you're there, and you say, oh, we got an IV that's maybe in a not optimal place anywhere on the right forearm, and you know, changing that out to the left side, and we've run into that a few times. So I think that actually is real world feedback that would be beneficial.
What about chemistries? Is lab work something that you guys can piggyback off of when they bring?
So I think that it's great to have lab work, because a lot of times if we are going to bypass the ER, you know, that's where that becomes pretty vital, because a lot of times you know, I've actually had patients who I did not get, you know, they had the blood drawn and then they got lost, and then like I'm, you know, sitting there telling myself, okay, I got to get blood work after the case, and, you know, draw it off the sheath, and of course, you know, forget to do it because you're not, you know, you're focused on the STEMI and things like that. So I do think that, you know, having that blood work ahead of time, especially if it's a, you know, bypass scenario, a straightforward STEMI, in which we're bypassing the ER, because then when, you know, they could just take that blood work that is drawn in the field and take it right downstairs, and you know, then 10 minutes, you know, when we're doing the case, is the CBC back yet? You know, and we're talking to the staff and they're checking it out. So that's a great point, Caleb, too.
Should there be any worries about an IO insertion, whether it be humeral head or femoral, for your guys' end, if we're unable to get vascular access?
Not especially. I mean, I think that in a arrest scenario, certainly
Right.
everything is off the table. I mean, I think that it always becomes then, if it's not an arrest scenario and we see an IO in, and somebody, if they've never seen an IO, they might get a little, a little scared from it. But I don't think it's optimal. But of course, if there's no other access,
That's what you got,
That's what
yeah.
you got.
Any
That's what
port in
you're
a
doing.
storm,
That's
sure.
what you're doing.
Fantastic.
Would EJs be okay too? Is that something that's not?
Yeah, I mean, again, I think that not optimal, but thinking of how it goes, and you ask the right, what is the throughput, right? Well, you guys bring them in, and we're standing in the bay, right? And if there's no IV access, right, then somebody just grabs, and I'll sit there and I'll be talking to the patient and watching somebody, poke away and not be able to get access, and that goes. So I think that an EJ in that scenario is acceptable and would be good work.
What would happen eventually is, we would get him into the lab, and once Dr. Stefano would get arterial access, then we could get a femoral venous access, or venous access somewhere else in the lab. So if we needed to get the patient into the hospital and get him to the cath lab safely, you got to have access.
Yep.
And then when we get there, we can always upgrade using imaging. So.
Yeah. You want to tackle that online question?
Yeah, any more?
One more quick question.
trying.
Sure.
To piggyback onto that, how often would you recommend us doing like a 12 lead? So once we find that we get that first STEMI, we send it to you. Is it kind of like at a critical call, we get vitals recommended every 5 minutes for an unstable patient? Would you recommend as well getting a 12 lead every 5 minutes? Or if we, for us, again, we have long transport times. Our average is 20 minutes, sometimes even longer. 15, 25 minutes is probably between those. So is there a good time to get another one? Would you recommend?
Great question. I think a lot of that would depend on what the initial EKG shows. I think that if we're talking about two separate scenarios, one would be STEMI, grossly identified. I think that if you see that there's a STEMI and that there's no alterations of their pulse, like they're not in complete heart block or anything like that, I think quite frankly you don't need to get another one if it's been identified and it's there. Now again, if you notice that their heart rate drops to 35, okay, well, are they in complete heart block? That would be maybe a scenario then to get another EKG in the STEMI pathway. But I think that if it's a STEMI identified, no real change with patient condition, there's no need to get another one. I think that if you have a patient who has chest pain and that you're concerned about, and then the initial EKG looks okay, or maybe some ST depressions, I think then in that scenario, then a repeat EKG, 5 to 10 minutes later, looking to see if there's ST segment elevations then that have evolved, that would be the way to go.
Anybody else?
Good questions.
Yeah, this is why we're doing it. Yeah, this is what we want how we want this to happen. Yeah, this is great.
So forgive me if you may have discussed this. I kind of came in late because we were on a run, but it deals with the DUACs that you were talking about earlier. If patients are on a DUAC, really there's no contraindication to giving them heparin, aspirin, Brilinta. Obviously if they're allergic to it, then don't. But you'd still want to give heparin, aspirin, and Brilinta even though someone is on a DUAC?
Yes, if that within the STEMI protocol, yes. That is correct. They've developed a.
So if a guy who's coming to the hospital is on Eliquis and he's having a STEMI, they're going to get aspirin, Brilinta, heparin.
That's
Yep.
all I need to know. Yeah,
Yep.
Thank you.
Yeah, no, and there's, there's always the case or the one
Yeah.
time.
Right.
But again, I think that in the setting of a pretty clear-cut STEMI, there's no hesitancy about doing that. And a lot of times, we're the discharge anticoagulation is always evolving. Patients who are on DOACs, these days, I'm usually sending them on just that on P2Y12 inhibitor and their DOAC. Some people will do triple therapy, but I think that there's enough strong data there now that we can do, P2Y12 and DOACs alone without aspirin. But again, a lot of patients on DOACs, and we've done this a lot. I think that I feel that it could be done safely, and the mechanism of plaque rupture needs to be antiplatelet driven, getting aspirin and P2Y12 on board, and then heparin for support. So yes, yeah.
Anybody else? No, come on, hey, keep them coming.
Weird question. So for a patient where we struggle with getting IV access, and they are a dialysis patient and they have a port, is it okay if we give the medications through the dialysis port? And have you guys ever, like the fistula, have you guys ever done that before, had to do that in your settings as well?
Good question.
No, I would advise against that.
Yeah.
Okay.
Yeah, I think that I would not cannulate a port.
I think in the world of IOs that we have now, I think there's better options. But I mean, that vascular graft that is the fistula now is
Yeah.
really hardened and weak. It'll cause some issues, I think, down the stream.
Yeah, that's a great question though. But I would avoid doing that scenario.
That's your case for the EJ or the IO.
Yeah.
Exactly.
Yeah, absolutely.
Yeah, good questions though.
Anybody else? All right, we gotta get guys.
Is that okay? I have one more.
No, as many as you want. That's why we're doing this.
And I might have missed this too, I'm sorry, when I was gone. Regarding right-sided EKGs, are you still really heavily asking us to do them, especially if we see an inferior wall, MI?
I certainly would not be if it's been identified. I think that in the setting of ST segment elevation, inferior MI diagnosed on a routine 12 lead, I don't think you need to do necessarily right-sided. There's always the case for right-sided and posterior leads in other scenarios when you have it's a normal ECG and then a good clinical story. I don't want to dissuade from that being done, but I can.
Right.
Practically, over 12 years, the amount of times that I've seen a STEMI on a posterior or right-sided that did not see on a 12 lead, I'm not sure I can remember one.
I mean, and how different is your treatment path for that patient? Should it be a posterior at this point?
Well, the treatment path doesn't change
Right.
in terms
Right.
of what the location is on the EKG. It's still aspirin, Brilinta, and heparin. It does give the acuity piece a little bit, because a lot of times a common scenario, right, is where you have a inferior posterior infarct, right, and this is the one where you flip the EKG over, right, and you see ST elevations in V1 and V2 and that scenario. But you also see that ST depression, because it is just ST depression on the right side of the EKG. You can see that with ischemia, and it's not an ST segment elevation. So in those scenarios, that might doing the non-standard 12 leads might give us a little more data, but it ultimately will not dissuade the course of going to the cath lab. If that makes sense.
And from a protocol standpoint, in 23, we made a pivot, which was essentially always do the right side of EKG on inferior, all that classical teaching that we've heard for years and years and years and years, right? And the pivot there was really to say, if you've got if you've got elevation, you've got elevation. What else do you need to know? Why are we wasting time taking another look, right? But the only thing that kind of pushes you to now in the protocol is if you have a clean EKG, but you have a great story, right? To his point, then take a look around. If you got time, right? If you've got the time, take a look around. Do that right-sided EKG. But otherwise, if you've got a hot anterior 12 lead, why are we looking at our left EKG? Why are we wasting time on a right?
Yeah,
So-
and clean, good
So that's
story
changing
too.
protocol, yeah.
I mean, even if you have a good story and you have an EKG that's clean and you did the right side and it's still clean, it's still going to take
Still,
chemistry
absolutely.
and
Yep.
Dr. Stefano
Yep.
and then the team to look at that to say it's not a
Still
non-STEMI.
very well maybe, right?
So,
I think we've said that 100 times
Yeah.
on the show, right? The story tells all,
Yeah,
right?
you're
The story
right.
tells all.
the best thing you can do is talk to your patient.
And as well too with nitro, and they say like, giving nitro, like also, that's the reason to do that right-sided, like consider before you give it? Is that something too that,
I mean, that's a good question. I mean, I think that, we traditionally, you don't want to give nitro to patients with inferior MI to, you want to drop their reserve and they become really hypotensive at times. But again, I think that I'm not sure that would be a scenario. If you identified an inferior ST elevation, then you're in that scenario where you might not want to give nitroglycerin for even normotensive patients. So I think that it's fine not to.
All right. This online question. Did you have another? You sure?
I'm done.
I don't believe you.
Think about it for a minute.
Yeah. She hesitated when she put it down. All right. So I'm going to summarize this and not read this whole thing. But the question revolves around Scarbosa criteria, and in the pre-hospital environment, is it or is it not reliable? So first of all, can you talk a little bit about the criteria for those who don't know what it is, and then reliability? Is this something we should be doing in the in the field, and validity of it? Personal opinion.
Well, I think that, it's hard enough for interventional cardiologists to try to mull through the Scarbosa criteria and in full disclosure,
Fair.
when I'm asked it, I need to, look up all 3 criteria, or 3 to 5, depending on which one you're using.
Right, yep.
In practicality, I mean, I think that, when you have a left bundle branch block, right, we all know what that QRS complex looks like, especially in the, precordial leads, particularly in V3 through V6, and you have those widening and bunny ears that
Yep.
come into play where you would traditionally see, right, ST segment elevations. So, I mean, I think that you have to sort of think about why, we're doing that versus just somebody told me, I got to check a Scarbosa criteria when there's maybe a left bundle branch block. So, the majority of times, again, that's not a subtle finding, when you're looking at a left bundle branch block. I think that the practical point I'd take home more so than saying, what are the Scarbosa criteria? It's a funny looking left bundle, right? It's not just if they have a left bundle, and they have chest pain. That is not a STEMI. Like any, all the Scarbosa criteria in terms of, concordance, positive in V5 and V6, it's not going to look like a left bundle. I mean, it looks like a STEMI in a left bundle. So I think that, personally, I think that it's a challenging scenario that all of us who take care of acute patients, sort of get funneled down a trap in a way. I mean, I think that, it's 99% of the time a left bundle's a left bundle and not a STEMI. You see that ST segment coming up through there. So, I mean, I think that, of course, there is some utility, but again, I think it's, more the Scarbosa criteria is more of a classical academic
Classical teaching, yeah.
than really practical. But I don't know if you have any other input with that.
You'll see it get mentioned once or twice a year, but it usually pans out to be, like you said, be just a left bundle.
I think go back again to your patient's presentation and then your chemistries. It's like S1Q3T3. The first sign for a PE is generally tachycardia, not S1Q3T3. So it's another tool in the toolbox, but
Not necessarily stamped up.
yeah.
Yeah.
And I certainly wouldn't look for it. I wouldn't know what I'm looking at.
And truthfully, how many STEMIs we've activated on a new left bundle has not been many that I can recall.
Fantastic. Anything else from anybody else in the?
You want to even look at that one or no?
What's that?
Since we're talking about Scarbosa criteria, it just seemed like a few months ago, I had a situation where we had a guy that really was having chest pain, like he just looked toxic. And put him on the EKG, and I'm like, oh my God, this guy's a third-degree block. Like I knew that can be extremely challenging to determine whether someone's having an MI. So I ultimately wound up sending the EKG to the ER and talked to the doctor and said, hey, listen, this guy, to me, he looks sick and he's having chest pain. Is there any problem with giving the heparin, aspirin, and Brilinta? Maybe you're wrong, and maybe it's not an MI. I guess from an ER standpoint, would they just consult cardiology to determine whether this person is having an MI? Do they send them off to the cath lab? And then it just is kind of a dry run situation where they send them home afterwards?
Yeah, I think that, a patient like that who's, having, acute chest pain, and I'll take the heart block piece out of that, because I think that there's, that probably was playing a role in as well. If a patient sort of has a new syndrome, and heart block complicates a lot of, acute MIs, it certainly sounds like that could have been a scenario where the patient was having an MI and you were all over it. And I think that, again, in context, if you feel that they're having a MI and they're within, our guidelines, that, you should not be hesitant to give, the aspirin, Brilinta, and heparin. I know it's recurring themes.
It's
but it's tough because you hear, even within my peers, you might get a different response. I'm not talking willy-nilly, but I mean I can we've done a lot of acute MI cases, and these protocols are pretty fantastic with outcome production.
And there are cases that Dr. Stefano will do where if they have a RCA blockage, you'll see her third-degree heart block, and they sort of present simultaneously. Like he'll bring the patient into the lab. You guys will have given the meds. We may put a temp wire in to help protect the patient's rhythm, and then open the RCA. And once you open the RCA, the third-degree heart block resolves. So they do happen simultaneously.
Concurrently.
And I think you hit the nail on the head with your story. You said that you saw something that didn't make sense, so what did you do? You called and spoke with med direction and got direction, and that's why they're there, and we can't be afraid of that. I don't like to say there's any dumb questions at med control. If they're calling, it's usually, and hopefully you're not asking for the dose of albuterol.
It sounded like it was a tough call for even the ER doctor to make, like, boy, I mean,
but I think though in that scenario though, like I said, I think then there's the two sides of it. I mean, we want to, you need to have confidence that if you're having an MI, that okay, this is what we're doing. But I mean, if there's again some equipoise there, do you want to? If it's not clear cut, I mean, I think Caleb said it. I mean, just you're in communication with a provider, and you could talk it over there. But again, we don't want you to worry you're missing something
Right.
and overtreat. You know, I mean, I guess that's always the tough message when we're talking about, you know, time and diagnosis. And, you know, yes, it is about getting, you know, the anticoagulation on board early, but a lot of that too is getting the people and support, you know, ready to go. I mean, that's why it's most important for diagnosis. You know, is to get everybody ready in the lab in motion to come in and get going. Again, I think that, you know, no one is going to, like in this scenario, right, if the patient's stable and doing okay and you're like, I didn't know, and they didn't get meds. I mean, we see it all the time. Did they get meds? No. Okay, give the meds. Like I mean, it's okay. I mean, it's not like it
wasn't clear cut.
Yeah, I mean, it happens all the time. So I think that, you know, being able to be comfortable, you know, when you're by yourself in an ambulance, taking care of a person with a life-threatening situation, I think that, you know, my response would just, you know, do what you're confident in, you know, and ultimately, you know, it's the doctor's credo, you know, do no harm, right? I mean, I think that's you know, a piece that as we continue to ask the front lines you know, make these decisions. I mean, it really is. It's a tough scenario sometimes for certain, but I mean, I think everybody really does a good job with this. So.
Get good vital signs, get an IV, give them a bag of pasta water.
We are running up against time here. I want to, you know, thank everybody online and all of you here in person. And on behalf of the podcast team, Lieutenant, we'd like to give you a challenge coin here that is in Ray's left pocket that he already forgot about.
No, we already did.
Oh, we already gave it to him. So, fantastic. I'm glad we scripted that so well. But from our team to yours, thanks for having us out here. This has been great. Thank you for all the great questions. And out in the internet world, thanks for letting us hijack your Monday evening. And you know, like us on Facebook and subscribe to the channel on YouTube. We'll catch everybody next time. Thanks a lot.
Thanks, guys.
Thanks.
Thank you.
Thank you.